Hold on. Please go ahead.
Hello, everyone. Dr. Amy Hipschman here. Happy to introduce Dr. Kenzie to you for this session. The title is shown on your screen. Dr. Kenzie is a senior analyst at the Oregon Rural Practice-Based Research Network at Oregon Health Science University. Her research focuses on application of system science methods to pragmatic research. Her PhD is in system science from Portland State University, and she has a background in the social and behavioral sciences. Without further ado, I give you Dr. Kenzie.
Thank you so much. I appreciate that introduction. So I recorded my presentation ahead of time, so I could be available in the chat to answer some questions, and then there should also be some time at the end. So I guess go ahead and start it off. Thank you so much. Hi, everyone. I'm Erin Kenzie, and I'm going to be talking about how systems diagrams can support the work of pragmatic research teams. So I'd like to start with the idea of complexity. So it's no secret that the contexts in which we do our research are often complex, and the interventions that we study often involve multiple factors and levels. Many people have said that we need to account for this complexity somehow in our research, but the methods for doing that haven't really been well established or integrated into standard approaches. So the research I'll be describing today examines how we might be able to adapt approaches from system dynamics modeling to support planning and decision-making within research teams in a way that goes beyond the standard conceptual models. So first, I'd like to start with a recognition of dynamic complexities. This is different from detail complexity, which just means that a lot of different factors are involved. With dynamic complexity, it's recognizing that complexity arises from the interaction between variables over time. And it emphasizes interdependence of factors across multiple scales, a contingency between those factors, unpredictability, and the conditional nature of relationships between determinants and outcomes. And what that means is that sometimes determinants only work in combination with other factors. So when applied to the context of pragmatic research, recognizing dynamic complexity means looking not just at barriers, but at drivers, feedback, goals, various kinds of what we call causal structures. So I think the way models are developed and used in system dynamics can be instructive for how we might want to think about using conceptual models or frameworks in pragmatic research. So I'm going to run through the standard modeling process from Sturman really briefly. So the modeling process starts with a recognition that there is a real world out there with its own complex dynamics. We get information about that world, and then we form mental models about how things work. So these mental models are always shaped by our prior experience and our interpretation of what we observe. So in groups like research teams, you can have a mental model that's shared if you have a common understanding of what you're studying, or you might have a variety of mental models. So we use these mental models to develop strategy and decision rules in teams and organizations. And then those rules help shape decisions, policies, programs, which then change outcomes that we observe in the real world. So what I'd like to draw attention to here is the distinction between the real world as it exists out there, our own mental models of that world, and then the models or frameworks that we create to help improve our understanding. And that's in the center oval here. So the modeling process starts with problem formulation, which involves identifying the issue you want to address and the boundaries of what's inside your scope. And the problem here is defined in terms of how key variables change over time. So an example of low cancer screening rates, you could define the problem by comparing trends of actual screening rates to a recommended goal. So then as a team, you develop what's called a dynamic hypothesis, which is a working theory or understanding of how the problem arose and is perpetuated. So in the cancer screening example, the dynamic hypothesis would describe what the study team thought about the causes of low screening rates and the interactions between those causes. A dynamic hypothesis reflects the mental model of the people involved and can change as they get new information. So when done well, the dynamic hypothesis reflects the dynamic complexity of the real world situation being described. And like I just mentioned, dynamic complexity involves an understanding of the world as highly interconnected, constantly changing, kind of constantly churning. And the dynamic hypothesis should describe the set of causal structures the team believes to be most important to producing the outcomes that we see. Then a diagram or model is created based on that dynamic hypothesis. Models are tested and validated to make sure they work as intended. For simulation models, this involves comparing model output to real world outcomes. And then once you have a model that seems to capture the key dynamics of the problem, you use that model to identify various points of leverage for changing the system and evaluate the anticipated effectiveness of different interventions. So I think a key takeaway here is that in systems modeling, you start with the problem or situation you're interested in changing. You develop your model to capture your understanding of the causal structures underlying that problem, and only then do you evaluate possible interventions or strategies for changing that system. So you could say that the problem or context and all its unique dynamics are put at the center of your understanding, and then the new interventions or strategies for changing outcomes are seen through the lens of how they may or may not shift those dynamics in a lasting way, the dynamics of the context or the situation. So this is very different from sort of more standard implementation or policy studies where we start with an evidence-based intervention or practice because we know that works somewhere else. And then we think about context when we're trying to implement in a new situation. We think about the context through the lens of that intervention. So we think of what might facilitate or provide a barrier to that intervention. So I'm not suggesting we should always follow this process or scrap all of evidence-based medicine or policy. Of course, we need to be guided by evidence. But when it comes to how we conceptualize our research in individual studies, I think it might be valuable to think about what we put at the center of our understanding and what we see as more exogenous. And this can take a lot of different forms. You don't always have to build a model by any means or go through a certain process, but there may be a tension to be aware of between wanting the conceptual models we use to truly reflect the complexity of real world settings and give credence to that, while also wanting to draw from existing evidence or generalized knowledge. So now I'm going to switch gears and talk a bit about how we've been using systems diagramming to support an ongoing intervention study. So the question we're asking in this study is basically how mailed fit and patient navigation, which are two evidence-based interventions for colorectal cancer screening, can be adapted to rural settings. And this study is called Smarter CRC and is part of the NCI-funded Access Consortium. And the problem definition that we're starting with is that CRC screening rates are currently below what they should be, especially for rural and Medicaid populations. So we're using causal loop diagramming to illustrate the usual care and intervention scenarios for this study. And I've put two links here, one directly to the diagram and one through a walkthrough that I'm going to switch to in a moment. And this is going to be the second version of the diagram we've worked on. We created one at baseline based on an iterative process of discussion and model development within our research team, which that one reflected the study team's mental model at baseline. And then this version reflects some refinement during implementation. We're still in the middle of this study. Oops, wrong one. I need to switch over to this one. So the first thing we notice is the complexity, right? But I'm going to walk us through this. So we're going to start with the usual care scenario, which is all the factors influencing low CRC screening rates within the study team's mental model. And if you open this diagram on your own, you can toggle the view down here between usual care and the different intervention scenarios. And you can also toggle what level, like clinic, patient, etc. So we're starting here. So of the population of people who should be screened for colorectal cancer. Some are identified by clinics for screening. The notation in causal loop diagramming is pretty simple. The arrows reflect when an increase in something results in an increase or decrease in something else. And so colonoscopy is the most common form of screening. It used to be the only option, and it's still seen in many places, especially rural areas, as the gold standard. This feedback loop here is B1, describes how when people are in need of colonoscopies are referred, let me zoom in a little bit. When people need colonoscopies and are referred, they schedule, they get the colonoscopy, it reduces the number of patients in need of screening. And patients who are higher risk for colorectal cancer should be screened with colonoscopy. That's the standard of care. But colonoscopy can be challenging for patients to complete. So it's an invasive procedure with unpleasant prep. You need to take time off of work, have someone drive you home. It can be hard to find an appointment. Patients can be reluctant because they don't understand the importance of the procedure. There can be cultural stigma, fatalism involved. People just don't want to know. And rural patients face additional barriers, such as long distances to specialists. And what's interesting and something we've incorporated more recently into this model is that we found that we've quite a few examples of primary care physicians performing colonoscopy for their own patients to help reduce some of these barriers. So as an alternative to colonoscopy, some clinics offer at-home fecal test screening for average risk patients. And one of those is Cologuard, which is kind of an all-in-one package for the clinics of this at-home test and some follow-up with patients. This option isn't available to Medicaid patients in all states. And then another at-home option is FIT testing, which is similar to Cologuard, but is handled by the primary care clinic. So patients who receive an abnormal result from Cologuard or FIT screening are referred to colonoscopy for follow-up. But a lot of times people do not follow through with this, which is a problem because these are folks who are much higher risk for cancer. And then patients also face barriers with visit-based FIT screening. They have to be engaged in preventative care with their clinic. They might not understand how to use or return the FIT. They might simply forget. The same issues around motivation and understanding the purpose of screening apply here too. And also some clinics are just not very familiar with FIT screening as an option or don't have the bandwidth to establish workflows for it. So any of these screening methods will depend on clinic level factors such as technical capacities and staff roles allocated to quality improvement or population health initiatives. Smaller, independent, and rural clinics tend to have fewer resources in this regard. And staffing challenges down here, particularly during COVID, interfere with clinics' ability to screen patients for a variety of reasons. And then in Oregon, Medicaid health plans, which are coordinated care organizations or CCOs, often provide support to clinics to provide preventative care. And then finally, we have patient social risk factors that impact all levels of this situation. And this is, as it is in the diagram now, it's kind of a placeholder. We intend to kind of unpack this and get more precise on exactly how these different risk factors come into play. So in Smarter CRC, we use a collaborative model to involve the CCOs and the clinics in establishing workflows for a mailed fit, which you can see here, which usually involves the CCOs and clinics working together to identify patients for a bulk mailing of fit kits, tailoring outreach materials, and then doing alerts and reminders. And with part of our study is that we have trained practice facilitators to support the mailed fit implementation. And they do training, supporting clinics in choosing high quality fit kits. They facilitate monthly implementation meetings, provide a range of other assistance to make sure it goes smoothly. And so our study also involves patient navigation to reduce barriers to follow-up colonoscopy for patients who do receive that abnormal fit. So as you can see, navigation is meant to reduce the patient reluctance. It's meant to address logistical barriers. They help troubleshoot transportation and other challenges for patients to get to their colonoscopy or to schedule those. And it also helps improve patient knowledge of the importance of screening and, an opportunity to get any questions they have answered. So, zooming back out to this big picture, it's complex, but it's still a simplification of the body of knowledge held by a study team. And you can see how most of the variables in the model reflect the usual care scenario. Let me just toggle to that. Most of the variables reflect this usual care scenario. And then the interventions and the implementation strategies are mapped onto that diagram to show exactly what kind of leverage we hope they will have. And so in this study, we started the diagramming when we already had the interventions and strategies planned out. Normal kind of, we proposed some research, got some funding, and then kind of incorporated some of this modeling as we got started. And the purpose, we've used this modeling, and the purpose was to get our thoughts onto paper so we could develop a shared understanding among our study team, and revisit and refine this during implementation, and then use it to support a scale-up phase of our study. And one example of that, so we're still in the middle, we haven't gotten to scale up yet, we're starting to do this planning, but one example of how we might be able to, how this could be useful is, for example, in the scale up, we don't have practice facilitators working closely with the clinics and there's going to be different situations besides CCOs. And so we can see, okay, what functions do the practice facilitators serve, for example, and then how can we figure out a different way, figure out different adaptations for meeting those needs in clinics in the scale-up trial. Same thing with the CCOs. They are serving a certain function in our study, in the Oregon study, that will need to be met differently in the scale-up. And so we can see, okay, what sort of loops is this affecting? How do these factors come into play to be able to strategize for that? So we're working on some of that planning. So, in general, a strength of having variables mapped out like this is that you can, make sure the strategies you're using are appropriate for the structure of feedback loops and variables. Again, we've developed this iteratively, different rounds of drafting and discussion among our team. There's lots of different ways, different sorts of knowledge sources you can use to develop these models. You can draw directly from, draw from literature review. There's a whole body of literature around group model building where you involve stakeholders. Typically that's done when there's, you want to involve a group in kind of identifying interventions and implementing them, and where they're kind of co-creating the model and identifying those strategies. So I'm going to switch back here if I can. So let's see here. So I wanted to briefly share one other diagramming approach called stock and flow diagramming. So these diagrams and causal loop diagrams have the same basic logic to them, but they're represented in different ways. So here I've recreated a very small part of that other diagram related to colonoscopy and mailed fit. And here you have stocks or accumulations. And in this case, the stocks are populations of patients who need screening, are identified for screening, and then referred for FIT or colonoscopy. And then a stock of patients who are up to date and then time into needing to be screened again. And the flows between these stocks represent how people move through the system. And the arrows, the variables with the blue arrows are pieces of information that influence how that movement takes place. The stock and flow diagramming can be a bit more intuitive for certain situations, especially ones kind of resembling workflows. But the feedback loops can be less visible. So sometimes it's hard to see those mechanisms. But a big advantage of stock and flow diagrams is that if you have good data to quantify the rates at which these processes take place, you can operationalize it into a simulation model capable of generating graphs of system behavior over time based on different inputs. So you can have a sort of flight simulator, and it can be used as sort of a what-if machine for anticipating outcomes based on different interventions or policies or sets of inputs. So to recap, a system diagramming approach focuses on how system structure produces behavior or outcomes by capturing the interactions between factors at multiple levels. So it centers the problem or system and its context, starts with that, and then new interventions or strategies are seen as attempts to change system behavior, often in a good way. This isn't bad, but they're seen as something that, any attempt to change, any change attempt is seen as needing leverage and needing to be able to kind of be strategic for changing the status quo, because systems as they exist are typically deeply entrenched. They're they're kind of they have their own goals, and they have their own mechanisms that are working in a certain way, independent of any sort of change that you want to make of them. So with systems diagrams, they can be used kind of as a conceptual model by research teams, in that it can serve as a mirror for the study team's mental model. And it can help align the perspectives of team members. It can also be used in planning and analysis, and it should be revisited and revised. And I should also just mention too, this isn't something that's going to take the place of conceptual models kind of writ large that are generalizable across different situations. There's definitely a place for those, and we can learn from those when creating sort of site-specific or study-specific, situation-specific models. But this approach is time-intensive. It requires some training to be able to do effectively. So I think there's some interesting questions for research here. One of which is, which causal structures are, the feedback loops, the links, the variables, which combination of structures are common across different contexts? And so how generalizable are certain things across, certain types of settings? And can template models be developed for specific interventions or contexts? So what does, how similar is colorectal cancer screening or mailed fit interventions in our Oregon study to the same in a different context? And what are the best practices for developing and applying diagrams for pragmatic research? And then how can they be used alongside more linear categorical models and frameworks to kind of get the best of both worlds? So I'd like to thank our funders, and I am looking forward to some discussion. Thank you so much.
Hi, thanks for watching the presentation. I see one question so far here, and it was around comparing causal loop diagrams to process maps. And I think it's a good question. I think there are some significant differences. So if I'm understanding process map correctly as a diagram showing steps of a process of what order things happen, that is, I think it's one way of looking at a situation, but it's different from causal loop diagrams, which are more about these causal relationships of what increases what, and what are the structures of feedback loops. And so this is different from events, because in a causal loop diagram, this is kind of more a map of what are the possibilities in a complex system. So you can look and see, okay, sometimes certain loops are more active or dominant, and sometimes others aren't, but they're still part of the system. So you can kind of look at it as what is someone's mental model of what can happen in this system, whereas a process map tends to be more, here's this intended series of events. So I don't know if that fully captures it. Let's see, other questions here. Yeah. Okay. So there was a question, it looks like, about publishing this type of work. Yeah, publishing giant, sometimes spaghetti diagrams can be challenging in a traditional journal format. That's why I really like formats like Kumu, where you can kind of scaffold people into a model. What we've done before is publish a interactive diagram alongside a journal publication, which can be one way to do it. I think sometimes, these diagrams, you have to think about whether you're using it as a means of communicating with outside partners or the research community, or, sometimes this can be used just for internal communication. And then it looks like one more question. Interested how this might be used with community stakeholders doing things like participatory planning, evaluation, right? Causal maps. You can provide an example of community work outside of clinical settings. Sure. I'd also like to direct you to Ellis Ballard's presentation following mine. We kind of divided up. My focus was going to be more around the internal kind of decision making within teams, and then his focus is specifically on that topic around engaging stakeholders in this process. I'll just say briefly, though, that there is a very big literature around group model building or participatory system dynamics, collaborative modeling. There's lots of terms, but there's great opportunity for involving people kind of from the ground up in co-creating a model that reflects their understanding, which can provide a good mirror for people to understand what how they understand the system, how their other fellow community members understand a system, and then be able to strategize about ways to help change that. So it's a similar basic idea of what I'm talking about, but there are ways to engage people. There's standards for kind of facilitating that process. And one more, if we have, much longer do we have for questions? I have maybe one more.
Yeah.
Oh, it looks like there's a question in the
5
room,
minutes.
maybe 5 minutes. Okay. I'd like to maybe share my screen unless there's other questions right now. I have one more point maybe I'd like to make.
I think you should go for that.
Okay, let me share. So as I was listening to my own presentation, I realized I should have maybe given a bit more detail on exactly how, an example of how these sorts of diagrams can be helpful within implementation. So for example, I mentioned the patient navigation intervention that we're looking at. And patient navigation is having people trained within, in our case, within the primary care clinics to help the patients along the process of scheduling their follow-up colonoscopy and following through with that. And, you know, so for example, if with using these sorts of diagrams, one thing that is helpful is interpreting unintended consequences. So for example, during a implementation, if you're finding that the uptake of patient navigation within the clinic isn't what you hoped it would be, you know, you can look into here to see, okay, are our assumptions correct? Like, is this basic set of assumptions correct? Do we need to change our assumptions? What exactly is not working here? So for example, like, are we not training people correctly? Is it the staffing challenges? Is that a pressure? Maybe there's something, you know, maybe the downstream impacts of the navigation aren't exactly what we hoped they would be. Maybe folks aren't seeing the benefit from it. So it's a way to kind of revisit what were our starting premises for this intervention, and how do we, and what sort of strategy, what are the strategies supporting that, and how can we maybe adapt or switch gears as needed. So I'll stop sharing here.
Yeah.
Any
Excellent.
final questions?
I do have a question.
Question in the room.
Can you hear me?
We're going to bring a mic over to you.
Okay.
That'd be great.
Thank you. I really appreciate your presentation. My question is that I noticed on the mapping that it seems to be mapping both. We know there is complexity in the system itself, but also in the intervention, multi-level interventions. And I noticed there was mapping of both. If that's true, if I got it right, how did you kind of dissect or elucidate where the variation is coming from? Is it the environment? Is it the intervention? Is it both? When? How? If you can expand a little bit on that, that would be great.
Yeah, I mean, I think you're absolutely right that there's complexity in the context in which we're doing research, and then there's also complexity a lot of times in the interventions. I think one, I think the answer to your question is kind of both and, there's, the complexity isn't going to necessarily come from one place a lot of times. And I think an advantage of having systems maps and models is that it allows you to kind of extend your mental capacity to wrap your head around all of that complexity. So it allows you to kind of spread it out, zoom in on a piece at a time, see, okay, what's my understanding of how this component works? Let's get this down. What's our understanding as a group of how this part works? And then you can zoom out and think, okay, what's appropriate? So if you have the kind of usual care or your status quo situation mapped out, you can look back and say, okay, what are our points of leverage? And ideally, your interventions are going to map on and be able to kind of respond to that system structure. So you can see, okay, we're doing, these trainings or these interventions here. Maybe we need to do something over here because this feedback loop seems to be pretty important to our system. So, and then with the simulation models, it kind of gives you a whole other layer of power and being able to think through that.
Dr. Perez says, yes, thank you. That answered your question. That brings us right up to time. Perfectly timed, Dr. Kenzie. Outstanding, wonderful presentation.
Thank you so much.
We'll take a 5-minute break here, everyone. And then as Jordan has put in the chat, Ellis Ballard will be presenting in this room in 5 minutes.
Thank you.